Welcome, everybody. Thank you for joining us today. We're going to get started very soon in a minute or two. We just have to let everybody get logged on in from the waiting room. Thank you so much for your patience. Really looking forward to our conversation today. Thank you so much for being here. We're going to get started in about a minute or two. We're just letting everybody get in from the waiting room, get situated, get comfortable, all of that good stuff. So I think I'm seeing a pretty sizable audience here. So why don't we go ahead and get started? Welcome, everybody. Welcome to our December. Oh my gosh, it's January, our first speaker series of 2025, our January speaker series webinar. Our conversation today will be with Brandon Peters, MD, a neurologist and sleep physician in the greater Seattle area, practicing at Virginia Franciscan Health. He's the creator of the Insomnia Solved program. He has worked in sleep medicine since college with extensive clinical and research experience in the field. His extensive sleep-related writing includes more than 1,000 articles on verywell.com, book chapters, Sleep Through Insomnia, Sleep Apnea Hypothesis, and countless other interviews and article contributions. So before we start asking questions, a brief reminder that these webinars are meant to be educational and are not meant to troubleshoot or consult on individual cases. As always, talk to your doctor about your specific care. If you do have a question, though, about this topic, please type it into the Q&A box below. But again, please remember that we won't be able to get to every question, and we might not be able to troubleshoot specific circumstances in this case. So with that, let's get started. So Dr. Peters, thank you again for being here. Is there any other introduction that I missed that you
No,
wanted to make sure the audience knew?
that was great. I appreciate that. And yeah, I hear those numbers of how many articles I've written, and it still boggles my mind. People should know that was over a decade of writing. So I would write maybe 8 articles a month, but it did add up over time. So a big number.
Yeah, not in one weekend. That's a good
No, no.
clarification. Yeah. So let's kick off actually with a seemingly easy question, but the more I thought about it, the more complicated it got. What is sleep? In a couple minutes or less, in your professional perspective, how do you define sleep?
It's a good question. So we can define it very formally, which we would say it's a transient, a reversible loss of conscious awareness of the external environment. We could also interpret it in what it's supposed to do for us, do for our bodies. It's obviously very important to growth and restoration of tissues, but it's also important for memory function and learning. And so it helps us to process the events of the day, to put aside information that's irrelevant to ongoing need and perhaps consolidate memory that might be important to us in the future. It can help with learning, helps with creative thinking. Sleep generally follows a very typical pattern. We call them sleep cycles, but these are 90-minute to 2-hour length cycles that will fluctuate between non-REM and REM sleep. We often go into deep sleep early in the night and have more REM sleep or dream sleep later in the night. The amount of deep sleep we get declines as we get older, so it can make up 13 to 18% of the night for the average adult. And it's, as we're older, not so much for growth as it is for repair of tissues, and it may help build muscle mass. REM sleep typically makes up about 20 to 25% of our sleep. What we call stage two sleep is the most common stage of sleep. That's about 50% of the night. And then we generally have less than 10% of the night in a lighter sleep called stage one sleep. But again, that's kind of a general sort of normative idea of what sleep is, what sleep should be.
The stages is really interesting to me, so I have a feeling we might come back to that for another review. But let's move on and talk about what is a healthy amount of sleep, especially thinking about people with rare diseases or autoimmune diseases.
Yeah, so you may hear that you need 8 hours of sleep. Well, what does that mean? It is the midpoint of a normal distribution. And so it's actually just over 8 hours, about 8 hours and 10 minutes is the average for adults. And it does vary throughout the lifespan. I would say that most adults are going to fall within a range of 7 to 9 hours. And some folks can get by on a little bit less without any serious effect. Some folks need more, 9 or even 10 hours of sleep to really feel rested. In the context of other illness, the sleep need tends to go up, so that people need more rest in order to relieve symptoms of fatigue or other symptoms. Older adults, 65 and older, generally are thought to need a little bit less sleep. The total sleep time need declines over the lifespan. The amount of deep sleep declines early in life. And so there are changes that normally happen as part of aging, but 65 and older, I think most folks should be targeting at least 7 to 8 hours of total sleep time. And again, with illness or with chronic illness, perhaps a little bit more.
Interesting. The other end of that, I think I heard you start to say, but children need typically a lot of sleep, right?
Yeah, and yeah, certainly. Young adults, adolescents need far more sleep, may need 10, 11 hours, and younger children even more. I mean, a 2-year-old might need 12, 13 hours of sleep. Some of their sleep is happening during the daytime, especially during infancy and through early preschool ages. They're taking naps initially twice a day and eventually just in the afternoons. But by age 4 or 5, those naps often drop out and then the sleep is primarily occurring overnight. But yeah, children need even more sleep than adults.
Interesting. So you had mentioned, the sleep needs when we're thinking about rare diseases and autoimmune diseases. Sometimes they're higher to relieve some of that fatigue and some of those symptoms. What really determines what somebody's sleep needs are? Because they are a little bit individualized. So how do we figure that out, and what really why do we need more or less sleep?
Yeah. So again, things can change, and some of this is just normal aging, environmental changes, demands on our time, caregiving, work demands, other demands. So there's some normal variability to our sleep need or capacity, opportunity. And certainly in the context of an illness, things can change too, and there can be medication effects, treatment effects, other things that would impact our sleep. The idea that I would have for most folks is that consistency is helpful to our bodies. So having a consistent sleep-wake schedule, a pattern of sleep that's the same through weekdays and weekends is going to be beneficial. Your body doesn't know it's the weekend, and so you really want to keep things as consistent as you can. And so generally what I would advise patients or people who are having troubles with sleep to do is keep a consistent wake time. So set an alarm even if you say, well, I don't need to wake up with an alarm, I don't have anything I need to do, still set the alarm. It gives you an anchor. It stabilizes your sleep-wake pattern. Then also get 15 to 30 minutes of sunlight exposure as soon as you can after waking. Now, if you wake early enough that it's still dark, wait till sunrise. Some folks who live in the northern latitudes like I do may want to use a light box through the winter months as a substitute to that morning sunlight exposure. But 15 to 30 minutes of light exposure in the morning is a strong signal to your circadian pattern. So it helps to alert you. You'll feel more awake as you get up in the morning, but it also makes it easier for you to fall asleep. And then once you've anchored your wake time, you want to do a little math and say, well, I think I might need 8 hours, I might need 9 hours. You kind of back up from that wake time, and that's kind of your targeted bedtime. But you always want to have a sense of drowsiness, sleepiness as you're settling into bed. And so if that time rolls around and you say, gosh, I'm just not feeling it, I don't feel drowsy, don't feel sleepy, which might mean eyelids closing, longer blink, feeling drowsy, feeling sleepy. If you're reading the same sentence over and over because it's not sinking in. You're watching TV, but you've lost track of the story. Those are signs that you're transitioning into sleep or sleepiness. That would be your cue to go to bed. And again, ideally 7 to 9 hours before you're waking. If you are adhering to, let's say, 8 hours before that wake time, and you can't make it, you're falling asleep watching TV, you're falling asleep reading before that bedtime comes along, you would probably want to move your bedtime up from that point and keep moving it maybe in increments of 15 minutes or 30 minutes, as little as a week at a time. You can do it very slowly, but kind of march the bedtime earlier until you've extended the time such that you're able to get sufficient sleep. Now, some people, especially with chronic illnesses, need rest periods during the daytime too. And so there might be periods of rest mid-morning or in the afternoon, evening, when you're going to take some time to potentially rest or even sleep. I would keep those fairly short so that you're not getting prolonged periods of sleep during the day. Maybe 15 minutes, 30 minutes, 45 minutes, something that's on the shorter end of the spectrum. 2 hours of sleep in the afternoon is probably not going to be helpful. It's going to impact your sleep at night. Obviously, it takes away time during the day. So I think prolonged naps would be something to try to minimize.
Interesting. So, can you repeat the ideal kind of nap time again? Did I hear like 30 to 45 minutes?
Yeah, I would keep it even shorter, 20, 30 minutes. But yeah, no more than 45 minutes. If you get a longer period of sleep, you're going to get into other sleep cycles. So it's not going to be just like light sleep, stage one, two. It's likely that you're going to, with 90 minutes, 2 hours, you're going to have dreaming sleep as part of that nap experience. And it's harder to wake. You'll wake and not feel as rested, as refreshed. Again, you're robbing some of the sleep that might happen at night. And it's folks who are having a lot of insomnia at night where they have trouble getting to sleep more than 20, 30 minutes, or if they're awake more than 20, 30 minutes in the night, naps might be something they have to either shorten or eliminate in order to improve their sleep at night.
Interesting. I have a couple follow-up questions, but I think our next question kind of ties into that because you mentioned insomnia. So how can someone determine if they have a sleep disorder like sleep apnea or insomnia?
And these sleep apnea and insomnia often overlap, so that's important to recognize as well. So insomnia is a clinical definition. So we define it as somebody who spends roughly more than 20 or 30 minutes falling asleep at the beginning of the night. If they're waking in the night frequently, having trouble getting back to sleep, again, more than 20, 30 minutes of wakefulness in the night. They might experience early morning awakenings. The sleep that they get can be unrefreshing. So they have symptoms of fatigue. They may have cognitive problems during the day, concentration, attention, short-term memory may be affected. They may have mood issues, more likely to have anxiety, depression, or chronic pain complaints. So those are kind of the symptoms associated with insomnia. If insomnia happens at least 3 nights a week for more than 3 months, we would say that person has chronic insomnia. And someone with chronic insomnia generally would recommend a therapy called CBTI or cognitive behavioral therapy for insomnia to treat that condition. We can talk more about that later. Sleep apnea has a constellation of symptoms associated with it, often snoring, but not always, witness pauses in breathing. Rarely does someone experience gasping, choking themselves. They often are not aware of that. They may have dry mouth, clenching, grinding teeth, night sweats, palpitations at night. They might have heartburn at night, often getting up to pee in the night, and then might wake with morning headaches or feel unrefreshed, more likely to have sleepiness, drowsiness, fatigue during the day, and again, the cognitive complaints, the mood complaints. Sleep apnea also connects to other disorders. So untreated sleep apnea can worsen blood pressure and blood sugar control, causing prediabetes, diabetes, can potentiate heart arrhythmias like atrial fibrillation, risk for heart attack, heart failure, stroke, dementia, all the things you want to avoid the latter decades of life. It's a risk factor for those things. We will assess somebody typically by questioning them about these symptoms and then arrange a test. So to figure out if you have sleep apnea, we would either do home sleep apnea testing, sometimes the more formal in-center test called a polysomnogram. We're measuring breathing patterns from home. In-center testing, we also measure brain waves, movements, heart rhythm, some other things that we don't measure from home studies. But after that study, if we find you're trying to breathe, but there's blockages within the airway, you're not getting enough oxygen, and you're waking yourself up, if that happens at least 5 times per hour, you have sleep apnea. And if it's severe, it could be more than 30 times an hour. That severity matters because there's different treatments, but people can use oral appliances, CPAP therapy, which is a mask that delivers an airflow. Longer term, there's treatments like allergy management, weight loss. There's a new medication that was just approved for sleep apnea called Zepbound, which is a weight loss medication. There are surgeries, including an implant called Inspire, that can be used for moderate to severe sleep apnea. So lots of ways it can be resolved if it's present. But again, testing for sleep apnea, insomnia is basically symptom assessments.
Interesting. As a follow-up to that, actually two follow-ups to that. So one person asked from the audience, feels like that they can't fall asleep on their own for some reason, feel as if I have to knock myself out and would love to be able to nap. Any immediate responses or reactions to that, especially in the context of what we were just talking about with some of those studies and disorders?
And so I would think about sleep apnea potentially. Some folks who have trouble falling asleep initially, but then sleep okay through the night, may have trouble waking in the morning because they have a circadian delay. So there's something called delayed sleep phase syndrome, which means the person's a night owl. Hard to fall asleep initially, again, fairly normal sleep overnight, and then hard to wake in the morning. They often would adhere to kind of a late schedule. They might not go to sleep till midnight, 1, 2, 3, 4 in the morning, and then want to sleep in later too, often till 10 a.m. or or later, noon. So that's a possibility. Some people can't fall asleep initially at the beginning of the night because they have sleep apnea. As they're falling asleep, their airways relaxing and they're kicking themselves back to wakefulness. So they can't initiate a deeper sleep because as they're trying to fall asleep, their airway is being compromised. They wouldn't necessarily be aware of that. You have to measure that to know that. But um, the idea that I can't nap, or I'd like to be able to nap, but I can't, that's very common when someone has insomnia. We often say they're tired but wired. So they're exhausted, they're fatigued, but they don't easily drowse. Like they're not drowsy during the day, sleepy during the day. They don't easily nap. They wouldn't doze watching TV or reading. They don't have drowsiness driving. So like the ability to fall asleep is compromised both day and night. So they're awake at night, but also more awake during the day in a sense that they wouldn't be able to nap.
Yeah.
So I would, if you've not seen a sleep specialist, do if you're having troubles with sleep, whether it's insomnia, sleepiness, fatigue, etc. I think that kind of assessment can be helpful to sort these things out.
Yeah, yeah, interesting. And fatigue can be a complicated issue. It's definitely a symptom that GBS-CIDP and MMN patients are living with. And, on top of maybe some of this unrestful sleep that you're talking about, it seems like that can compound it. Would you agree?
Yeah, 100%. Yeah, and I mean, fatigue. We try to use different words to trying to parse this a bit. So again, we have this category of drowsiness, sleepiness, which is like the feeling you get right before you fall asleep. And so often people would say, kind of, I'm blinking and the blinks are lasting a little bit longer, or my vision's blurring a little bit. Again, I'm inattentive reading, watching TV. A warm feeling that kind of comes over the body, yawning. I mean, these are all potential kind of signs or feeling symptoms that would come with drowsiness, sleepiness. But fatigue, tiredness, exhaustion, low energy, that's a different kettle of fish. And that's often a physical sensation. It may compromise strength, it may compromise function in a different way, but it's not going to translate to sleep. And so someone can feel extremely fatigued, but it doesn't mean they're going to nap or doze or even be able to sleep at night potentially. And so we separate those so that we can kind of get to the root cause a bit better. If someone's having a lot of drowsiness, sleepiness, first we think about sleep deprivation, is the person getting enough sleep, but then we might think about other conditions like sleep apnea and even rare conditions like narcolepsy and idiopathic hypersomnia, which requires testing to understand. But fatigue, tiredness, that can be relieved if there's a sleep disorder present as well. Obviously, you want to manage other conditions that are contributing to that, which can include other medical conditions, hypothyroidism, anemia, and other conditions as well. But yeah, we try to separate those things out so that we can get better at the root cause and ideally provide some relief.
That makes total sense. And I think sometimes fatigue does just get categorized in this tired feeling. But I really like that you're acknowledging that this is kind of separate from your sleep, that this fatigue is possibly a physical symptom that may or may not improve with good, restful sleep, but
Yeah.
the sleep is something separate. We got another question from the audience. Do you have an opinion on a sleep tracker at home? Is there one out there that you like, or even just tracking sleep at home and all of that good stuff?
It kind of depends on what you're using it for. So for full disclosure, I worked with Amazon as a consultant for more than 5 years, helped them develop their wearable. They had Halo and another tracker that was a bedside tracker. Um, and these devices, theirs and others, are not 100% accurate as we compare them to gold standard assessments of sleep. Part of that is also how we measure things. These wearables often are dependent on movement assessment and heart rate assessment, heart rate variability. If you lie very still with a slowed heart rate, the device may think you're asleep, even if you don't experience that as sleep. Um, so there's not 100% accuracy with any of these devices. Many people use Fitbits, Apple Watches, Garmin's, and others, and I don't have a strong preference. I think their accuracy is all about the same. Again, I would guess 80, 85% accuracy compared to gold standard measurements of sleep. But ultimately, what are you going to do with that data? So if you wear a wearable and it's telling you you're sleeping poorly and you already know that, and it doesn't give you any advice or guidance on what to do with that information, I don't think that's a particularly useful tool. Ideally, these would give you some advice, or as perhaps Apple Watch is able to do, get you plugged into other assessments. So if the Apple Watch does a sleep apnea assessment over a month and says you have sleep apnea, and that clues you in, and then you go down the path of getting appropriate testing and treatment, that's useful. But something that just gives you a sleep score that it's always poor and shows you data that you may not fully trust, I don't think that's particularly helpful. Some folks use wearable data in a way that actually harms their sleep. And so that's called orthosomnia, which the Latin is straight sleep. So they're trying to have perfect sleep and they can't do it. And they get anxious and they get frustrated. And those things, of course, make sleep worse. It's really hard to manipulate some of these elements of sleep. Like if you said, I'm going to get more REM sleep, I'd say, well, good luck, because I have no way to make you have more REM sleep. You can take away things that suppress REM sleep, and that can be helpful, but there's no way to really boost REM sleep to our knowledge. And same with some of these other variables like deep sleep or core sleep. These are not things that are easily manipulated. And so it doesn't really encourage someone to make behavioral changes that would optimize sleep. And again, if you're getting poor results, you aren't going to find that a very helpful tool.
This is interesting. You're saying, it's hard to manipulate sleep. So, as a question of my interest, and then we got something similar from the audience, can you talk a little bit about sleep aids, medicines, the melatonin, and then some of the other ones? I don't want to name any brands, but I think you got the
Yeah.
picture.
Yeah.
And then somebody did write in asking about medical cannabis as a sleep aid, maybe as an alternative to some of that melatonin or some of those other brand name ones. So, any thoughts there?
Yeah, it's a big question. I could probably spend an hour just talking about sleeping pills. So first off, they're widely used, over-the-counter, melatonin, others, and prescription. The more recent data that we had from 2020 suggested about 6% of adults had taken a sleep medication every day of the prior month. And older women were more likely to use those medications. So that was up to about 13.5%. That's shocking to me that that many people are using these medications on a daily basis. The sleep aids are going to do one of two things. So they're either going to enhance sleep signals, which typically are going to be GABA, sometimes melatonin, or some of these medications actually block wake promoting signals. So those tend to be histamine, which promotes wakefulness, or orexin hypocretin, which is another wake promoting chemical within the brain. So melatonin, obviously your body makes melatonin. I would use very low doses if you take it as a supplement. It's not generally that effective. There can be side effects like headaches, nightmares, morning sleepiness. Antihistamines get used over the counter too, and those are going to be the PM drugs. Benadryl, diphenhydramine is an antihistamine. Doxylamine, which is like Unisom, another antihistamine. There are other prescription-based medications like trazodone, which are effectively an antihistamine medication. And then there's the other categories of drugs that generally are going to affect GABA and the GABA receptor. And so those are the most familiar drugs that people would recognize, the non-benzodiazepine medications, or what we call the benzodiazepine receptor agonists. And those are the Z drugs. So it's zolpidem, most widely used in the US, about 80% of the prescriptions. That's Ambien. There's S-zopiclone, which is Lunesta, and then Zaloplan is another one that's another Z drug. And there's, again, melatonin agonists, which are prescriptions. There are orexin antagonists, which are the newer drugs. There's three of those now. So those are the prescriptions that are available. And again, either blocking a wake promoting signal or enhancing sleep signals. Now, cannabis and other kind of natural things you might use. Uh, First of all, cannabis is not well studied. There's no federal level of studying, so it's more or less anecdotal data. People find CBD to be helpful to relieve anxiety and to enhance sleep. THC is going to cause hallucinations potentially, and so that's not the high of marijuana use. So that's not helpful to sleep necessarily. People will take them as edibles. They may smoke or vape to get the CBD. People generally find it's helpful, but I would say the effect can wear off. So long-term use may be something where it's not useful over time. Other natural things, plus minus about taking GABA, valerian root, chamomile. Serotonin or tryptophan supplements are just converted to melatonin, so you're really enhancing melatonin. The one supplement I would not use is kava kava. That's actually something that's associated with liver toxicity, and so it interacts probably with the GABA system and other systems, but that's actually a banned substance in Europe. So I wouldn't recommend using kava kava. But um, my general take on all of these different supplements, medications, and others, and they have some serious side effects, which we can talk about too, um, is that you don't take medicine to feel hungry. Ideally, you wouldn't need medicine to feel sleepy, and that there are other ways, behavioral changes we can alter our sleep wake patterns that can enhance sleep such that we're not dependent on the daily use of a medication. And some people do need these medications. So that being said, there are folks who, for whatever reason, have made the behavioral changes, are treating their sleep apnea, have ruled out other things, and they still can't sleep normally. And those people do need medications to be able to sleep better. Those are pretty rare folks. I can think of in the last decade of practice, perhaps a handful of people who truly cannot sleep without a medication. We measure them with a sleep study and they don't sleep. They're in bed for 8 hours, 0 minutes of sleep. They absolutely have to have medication to be able to sleep, but that's a rare bird. And unfortunately, again, 6% of the population is taking a daily medication that I don't think they need. That I think we can get away from these medicines that have side effects and potential long-term consequences.
So I think if somebody living with GBS-CIDP or MMN is concerned about their sleep, the first conversation that they should have is with their neurologist treating the GBS-CIDP and MMN and talk about their sleep, talk about any of the medications, because as a reminder, many patients are taking IVIG or other medications to treat their symptoms. So always want to be aware of that, that the doctor who's treating your condition knows what other supplements even that you're taking and all of that good stuff. And then so after the neurologist, would would a patient necessarily advocate to see a sleep specialist, or what would the next step be rather than just trying to self-medicate with some of those supplements or anything like that?
Yeah, I definitely would get plugged into resources. Uh, and keep in mind that CIDP is often associated with sleep apnea. I mean, these conditions can affect the muscles of the airway. People can have difficulties with swallowing and speech and other side effects or signs of the condition, but that also can impact breathing during sleep. And during sleep, there are changes that if you've got that additional hit against the muscles of the airway, that may potentiate sleep apnea or snoring. And again, you may not be aware of it. Your bed partner may not be aware of it. I would almost, as a rule, have an assessment just to maybe rule it out and say, nope, I don't have sleep apnea. But I think getting your neurologist to perhaps refer to a sleep specialist or getting your primary care doctor to refer, some folks can self-refer to sleep specialists. I would say sleep specialists can be hard to access. That's one of the problems, even in our system. It can take months to get in to see us. Some of the academic centers, it may take a year or more to get into a sleep specialist. So, unfortunately, it's a slow process, but we're trying to find creative ways to increase access. But I would say, yeah, start with a conversation with your neurologist, and maybe go from there.
The sleep apnea connection is interesting and maybe something I didn't always put together, but you're saying that there is maybe an increased likelihood of that in our community because of, the peripheral nerve involvement and the muscle weakness and
Yeah. Yeah, the airway muscles, and it's the tongue and the muscles that line the airway, again, can be affected in a way that would potentiate sleep apnea. And sleep apnea is just a partial or complete blockage of the airway, typically at the base of the tongue, but sometimes the soft palate or uvula get involved. And during sleep, the muscles of the airway are relaxed. During REM sleep, the muscles of the airway are paralyzed. And again, if you've got anatomy that predisposes towards this or other risk factors predisposing towards this, CIDP might be another hit against those tissues that would cause someone to have more snoring or more sleep apnea. And again, the experience of that might be I'm a light sleeper, I'm a restless sleeper, I'm fatigued, I have pain. Those can be symptoms of sleep apnea. And again, we don't want to just attribute that to CIDP without understanding that we've set aside sleep apnea as a potential cause.
yeah, absolutely. I think that's good advice in general for something like this. Anybody living with GBS, CIDP, or MMN, not every symptom or feeling that you're experiencing is just because of that. There could be other things going on, and sleep is a great place to look at as well to make sure that that's all working properly. So, Dr. Peters, we've gone so far off script, so let me try to bring us back a little bit. Let's talk a little bit about lifestyle factors, diet, exercise. Somebody wrote in asking about blue light and how that can impact sleep quality. So any thoughts about the lifestyle factors? You kind of touched on it before as being a way to improve your sleep. And then good cutoff time or rule for caffeine or other stimulants.
Yeah. And so, yeah, these are all important factors. I tell people health, it's nutrition, activity, exercise, and sleep.
Mm.
These are the big three things. And in the setting of a chronic illness, they're all even more important. Um, I would say we don't fully understand how nutrition diet affects sleep. There's a relationship there. There are certain foods that enhance sleep. There's certain foods that will inflame the airway, increasing mucus production, swelling. Some folks that can be dairy, gluten, processed sugars. Histamine-rich foods like red wine can cause nasal congestion, swelling. So there's a relationship there. And I would say the general advice around healthy eating applies and will help with sleep. Um, Exercise activity, very important. Someone who is able to get in a normal amount of exercise is going to improve their sleep, and you get a deeper sleep. There's less fragmentation of sleep. There's less wakefulness in the night. So exercise, very important. And it's in the context of other illness, it might be as part of physical therapy. It might be other things that you're doing to try to get some of that work in. But again, it's going to help deepen your sleep, help with growth hormone release, which repairs tissues, builds muscle, helps with pain control, etc. Now, the idea of light, very interesting idea. I would say I'm getting light right now because it's midday where I am, but you want light exposure through the day, and you want a lack of light exposure during the night. And I would say as your sun sets where you live, that's kind of the time that you want lights to be kind of turned down. You don't want blue light exposure after sunset because you want the more natural experience. Now, devices, screens can filter out blue light, which is helpful. The other thing to keep in mind is that it's not just the light that's activating, it's also the activity. So if you're staring at a screen that's got a filter on it, but you're on YouTube and you just keep clicking on more videos, or you're reading news that's upsetting to you, or you're working. I mean, those things are activating too. And so it's not just the light that can affect your ability to fall asleep, it's also how you're engaging with content and what that's doing to your brain as well. Um, so I would say it's good to set aside devices probably the last hour or two of the night at least. Watching TV across the room, that's fine. Many people do that and don't experience insomnia, so I don't think that's particularly worrisome. The balance to that, if you do get sunlight exposure at night, is trying to get that morning sunlight. Again, 15 to 30 minutes of sunlight exposure right upon awakening or at sunrise. Winter months, maybe a light box, but that's a very strong signal that will counteract any light exposure that you would get in the evening. So I think that's very, very important. Um, there was one more question there, which was around caffeine. The half-life of caffeine is 4 to 6 hours for most people, and that does vary based on your metabolism and other factors. But that being said, so if you take a cup of coffee at 9 a.m., with a half-life of 6 hours, that means at 9 p.m., 25% of that caffeine is still in your system. Now, it likely doesn't have much of an effect. You've built up adenosine and things that counteract that, so it's unlikely to bother you. But for some people that are sensitive to caffeine, they have to be careful of how late in the day they consume it. Caffeine after midday or after mid-afternoon might cause more insomnia. Some people are not sensitive to caffeine. I tend to not be sensitive. I could have coffee at dinner and sleep normally. So you just have to kind of know yourself and kind of where the cutoff lies for you. But a general rule of thumb is caffeine will stay in your system with a half-life of 4 to 6 hours, so it tends to linger.
It's interesting that there's not a hard and fast rule for it because I think sometimes we hear those hard and fast rules, but everyone's processing it differently. And I even notice in myself that some days it works in the afternoon and some days I don't feel affected by it. So that is very interesting, as well as the blue light. So if I heard correctly, it feels like counteracting that with the sunlight in the morning is almost more powerful in maintaining that circadian rhythm.
Yeah, 100%. Yeah, yeah, the light exposure off a screen, like an iPhone or other smartphones, other tablets and things, it's not a lot of light exposure. Even the fluorescent light above me is perhaps 500 lux of light. If I'm out in the midday sun and it's clear, which it happens to be today, you can get 100,000 lux of light. And so as you're balancing this out to say, oh, I got 400 lux, 500 lux of light in the evening, many hours before my minimum core body temperature, so the effect is lessened, versus getting that blast of sunlight in the morning. the sunlight is always going to have a more powerful effect on your circadian system. So if you get that light exposure as part of your morning routine, I don't really worry about that light exposure in the evening. It's not really going to have much of an effect for most people. Again, some people can be very sensitive, but again, not a very common thing.
More personalized. Yeah, I'm learning today that sleep is more personalized than I think I realized. So the light in the morning. So for those of us in the northern hemisphere, like you were saying, it's still pretty dark when we wake up.
Yeah.
What about those like sunrise alarm clocks or those light boxes? Or, not do we have to go outside to get the sunlight, or can it be like through a window? Just a little more guidance there.
Yeah, so being out in the light would be best. So when I trained at Stanford, we used to advise people to get 45 minutes of sunlight in the morning. It
Cool.
was a completely ridiculous recommendation because nobody would follow it. Nobody had an extra 45 minutes in the morning as part of their routine. So people didn't do it. But what we recognized, I think subsequently, is that people can get less light exposure, even short bursts of light exposure, and that can have an effect on the circadian system as well. So being in the sun is best. Now, I live in the Seattle area. It's often gray, it's cloudy, it's raining. So we're getting filtered light at best, but I still tell people try to get on some warm clothes and still go out into the light because it's still going to be better. You'll get more light than you would staying indoors. As you're staying with a window, you're filtering the light. The window's probably dirty. It may have tinting, it may have gases inside that are filtered. So you're losing some of the intensity of the light that way. If it's not direct, which it typically wouldn't be, it's incidental. Again, that's going to affect the intensity of that light exposure. If you use a light box, you would want a light box that's 10,000 lux of intensity. It's either blue light or full spectrum light, because that's how you can adjust the circadian pattern. Again, that threshold of at least 10,000 lux with blue light or full spectrum light. There are many light boxes available. They're often under $50. You can get it and use it through the winter months. And then as you're able to get natural light, maybe in the spring and summer, do that instead. You don't want sunglasses on. You don't want a hat or visor. You want the sun to be on your face. Don't stare at the sun, obviously. Just let it be kind of incidental, like the light is on my face now. You're looking elsewhere, but you're getting some of that exposure. The sunrise alarm clocks are interesting. Again, during my time at Amazon, we developed a sunrise alarm clock. It is not available anymore. They closed that whole program down, so don't look for it. But other sunrise alarm clocks exist. They tend to kind of warm up light to get into kind of the orange spectrum as they're and a little bit lighter as you get close to your preferred alarm time. I think they can be a little helpful. The unfortunate thing is you're often not staring at the clock as it's coming on. You might be turned away from it, and so you may not get enough kind of exposure to actually make it easier to wake up. Um, I would say again, natural light is best. If you can watch the sunrise in the morning or watch the sunset in the evening, those light exposures are far more natural and will help your circadian system.
Very interesting. Thank you. Thank you very much. I want to jump back and talk about stress and mental health and its impact on sleep. And I imagine that this is going to be a two-way street. So, any thoughts on how stress can impact your sleep? And then the opposite, how does sleep impact your stress and mental health?
Yeah, it's definitely a bi-directional relationship. And so obviously if you're experiencing a stress, whether it's related to health or finances or political stresses, geopolitical stress, I mean, there's lots of things that would cause you to feel stressed. It can make it hard to settle at night as you kind of ruminate about things, think about things. You might wake in the night and those thoughts immediately come back and you're sort of processing that. So there's definitely an effect on your ability to fall asleep. People with stress, anxiety will have more experience of insomnia. There's also a relationship to depression. People with depression often have extended sleep, unrefreshing sleep, daytime sleepiness, fatigue, prolonged napping. They might sleep 16 hours out of the day and not feel rested by the sleep that they're getting. Obviously, more significant psychiatric conditions like schizophrenia and bipolar disorder have effects on sleep as well. And then the relationship goes the other direction. So if you're not getting enough sleep, if you're not getting a normal quality of sleep, if you have an untreated sleep disorder like sleep apnea, these things will cause anxiety and depression. I mean, sleep apnea, as you're having an apneic event, your body responds by releasing cortisol, stress hormone. So you wake up with cortisol in your system and your heart rate can be up. You can feel sweaty. You can feel anxious. You can have mind racing as you wake from sleep. So there's a relationship in that direction as well. When somebody has both a mood disorder, let's say anxiety or depression, and a sleep disorder, insomnia, sleep apnea, etc., the money is on fixing the sleep disorder. If you fix their sleep disorder, both things will get better. If you focus all your efforts on improving mood through psychotherapy, counseling, medications, and ignore the sleep disorder, they'll continue to have both problems. You won't make as much headway. So it's ideal to approach from both sides. Say, I'm going to help manage mood symptoms, provide relief there, but also address the sleep issue that's present, and people will get the greatest benefit. But these things commonly overlap. I tell people sleep and mood walk hand in hand, and you really need to address both sides in order to really optimize daytime function.
Very interesting, and another reason to prioritize sleep. So we are over halfway. Thank you so much so far for all of that. A reminder, if there's any other questions, please make sure that you get them in. Can we talk a little bit about medications and specifically the medications that treat the conditions our patients are living with? So IVIG is the big one, intravenous immunoglobulin or subcutaneous IG, but some patients are also taking steroids. Some patients do plasmapheresis to manage their symptoms, things like that. So any thoughts on those medications that are treating the GBS-CIDP or MMN and how that might impact sleep patterns? Somebody wrote in that they nap during their IVIG. Some patients take, large doses of Benadryl or antihistamines before their IVIG. So if that's in the midday and then that makes them sleepy, kind of seeing a little bit of how that disruption might happen. So just wanted to dive into that a little bit.
Yeah, I think there's an important relationship there. And yeah, a common side effect of IVIG treatment is feeling tired, feeling fatigued, sleepiness, and other kind of flu-like symptoms. Those seem to increase around the time of the infusion, just after the infusion. And they can be mediated in some ways. So you might talk again about this with your neurologist, but it's possible that the infusion rate could be slowed, and that might be beneficial. That hydration might be important. So drinking plenty of fluids before, during, and after an IVIG infusion might be helpful. And then allowing rest after the infusion. So if you are sleepy, are tired, that you know your body, you respect the body and say, I'm going to take some time off work, off other responsibilities, let myself physically recover from this experience. And you'll get, I think, a greater benefit from the treatment. These immune modulation treatments are going to have an enhanced effect if you're getting adequate rest afterwards, adequate sleep afterwards. Steroids, especially high dose steroids, are notorious for causing insomnia. And so somebody who's maybe in an acute flare, who's using a steroid to help improve their symptoms, likely will experience insomnia. Now, again, not everybody. So if you say, well, I never had insomnia when I had my steroid, it's not everybody. I mean, everybody responds a little bit differently to these medications. And sleep is not a monolith where it applies equally to all. There are normal variations here. And so again, I would say you know your body more than anyone, and you need to pay attention to these things. And again, respect need. And if you're feeling particularly tired or fatigued after IVIG treatment, or if you're experiencing a lot of insomnia in the context of a steroid treatment, speak up about it. Let your neurologist know, let your providers know so that it can be addressed. And that doesn't mean, oh, now I got another medication I'm taking. It might mean behavioral interventions that can be helpful, including CBTI. It might mean other assessments of sleep if it's an ongoing issue. But yeah, IVIG and steroids both have pretty significant effects on sleepiness and overnight sleep.
Very interesting. And a reminder to our conversation earlier, we talked about fatigue being a symptom, but that sleepiness and that tiredness being something different and maybe indicative of something different going on. So being aware of that, it's not all the same and it's not all because of CIDP. So let's make sure that that all gets addressed for overall wellness. Another symptom that a lot of our patients live with and experience is pain. So what is the relationship between pain and sleep? We also hear a lot of the pins and needles or the restless legs. So any thoughts on those symptoms and their relationship to sleep?
Yeah. Yeah, that's a great question. So, and we can kind of approach it in different ways. But so, first off, why is pain worse at night? Why is it worse, perhaps at a time that you're wanting to sleep? The short answer is we don't know. There's something called the gate control theory of pain, which It talks about how the body processes pain signals via gatekeepers in the brain that allow the signals from the body to reach the cortex and our awareness. If these gates are open, we're aware of pain. If the gates are closed, we're not aware of pain. There's different regulators to these gates. Movement or activity can close the gates. A physical sensation or pressure like massage or gentle heat may also close the gates. Stress, anxiety opens the gates. And so you're going to have more pain awareness in that context. Cold also generally worsens neuropathic pains. So it's obviously colder at night and very cold in places these days. And so that can make pain awareness worse. There's a circadian rhythm of pain. So daytime production of hormones, including cortisol, that may suppress pain symptoms and pain awareness. Also at nighttime, we have a lack of attention redirection. So we're not thinking about something else. We're not doing something else. And so we lack that cognitive distraction that can also push us away from the awareness or the experience of pain. So, so lots of different variables there. Uh, it's interesting that pain may actually make it difficult for someone to fall asleep, but once asleep, we're generally unaware of pain. So sensation and pain are generally not recognized, especially in deeper sleep. But you can still pick up on correlated EEG changes if you cause someone to have pain during sleep. So it's not a total off switch when somebody's in sleep. It seems that poor sleep, inadequate total sleep time, poor sleep quality, untreated sleep disorders will increase pain conditions and symptoms. And so fibromyalgia is a condition that's often associated with a chronic pain. And a lot of folks with fibromyalgia have sleep apnea. So half of folks with fibromyalgia have sleep apnea. And again, treatment of that sleep apnea, recognition of that will allow improvement of sleep and reduction of pain. Neuropathy, including uh, associated conditions like restless leg syndrome or something called periodic limb movements of sleep, may be further disruption of sleep and may restless legs can make it hard to fall asleep initially. Also, leg movements can wake somebody. So if you're twitching and moving in your sleep, that can undermine your sleep quality. It might affect your bed partner's sleep quality.
Very interesting. So somebody wrote in to ask about CBTI. Can you just explain that a little more?
Yeah, so CBTI is cognitive behavioral therapy for insomnia. It is, so I trained at Stanford in sleep medicine and I was trained to do CBTI. It's generally done by psychologists. I'm a neurologist by training, but I happened to be trained in that when I was there because I was interested in it. I wanted to learn about it. CBTI is a 6-week program. So this is generally done in the context of one-on-one therapy, but it can be done as a shared medical appointment in a workshop. There's an online course that I created called Insomnia Solved. You can get to that would guide you through the program. There are books. My book that I wrote is called Sleep Through Insomnia, which is a CBTI based book. But you learn about sleep. Many of these things I'm telling you today, you can read in the book. So you'll learn about basic sleep needs, how sleep changes. You will learn sort of normative aspects of sleep, how to build a strong sleep drive, how to optimize your circadian rhythm. There's education around medications, sleep aids. There's education about dealing with stress or anxiety and reducing pain. Uh, there's mindfulness techniques, breathing techniques, muscle relaxation, guided imagery, other stress management techniques. And you track your sleep patterns either with a wearable or with a self-reported sleep log. Use that data to adjust your sleep patterns. And then there's also education about looking for other sleep disorders that might be having an effect as well. And so it's a 6-week boot camp for sleep. And so I think almost everybody will benefit from it. You will learn things you didn't know about sleep. You'll learn ways to manipulate sleep that you may not appreciate at this moment. And I would say most folks, not everybody, but most folks at the end of 6 weeks are sleeping better. Many people can improve and resolve insomnia as part of that experience. And the nice thing is you're learning skills that you apply the rest of your life. And so folks, years after completing a CBTI education, will continue to sleep better, continue to sleep normally, even in the context of other stress or other illness that comes along. They can do the things they need to do to optimize their sleep. So It is the first line treatment for chronic insomnia. If somebody has troubles getting to sleep, getting back to sleep more than 3 nights a week for more than 3 months. CBTI is meant to be first, even before a medication, before an over-the-counter sleep aid or use of a prescription medication. We're meant to use CBTI, and that's according to American Academy of Sleep Medicine, American College of Physicians. This last fall, I wrote something for the American Medical Association, Journal of Ethics about managing insomnia, managing with CBTI. So it is our best treatment.
Hmm.
Few, there's really no risk, side effect. Again, you're going to learn things that help you the rest of your life. And so find a resource, whether that's a local person that does CBTI or one of these online courses or books. I think if you have an issue there, it's 100% worth your while to work through that.
Yeah, thank you so much. And we'll definitely include some resources in the email following this. So anything that you want to share with us, we'll make sure that it gets to the whole audience and the group. So for the last 10 minutes, I have a couple of questions from the audience. So we're just going to go through these a little rapid fire here. So one came in about alternatives to CPAP. So patients have tried and unable to use CPAP. Any recommendations for oral appliances that are alternatives or alternative methods?
So yeah, the oral appliances are for mild to moderate sleep apnea. They'll be fitted by a local dentist. If you go to dentalsleep.org, you can find a dentist in your area that makes those appliances. And that can work well. You want to make sure you have a test of it to assess how it's working. Side effects can be teeth movement, bite changes, jaw issues. So that's why you want to work with a specialist to have that fitted. Not always covered by insurance, can be more expensive. So you want to look into your medical insurance coverage as well. Beyond that, weight loss, allergy treatments, positional therapy, staying off your back, elevating your head. Sometimes breathe right strips, nasal surgeries, turbinate reductions, which clear the nose. For some folks, if their tonsils are enlarged, younger children especially, jaw surgeries rarely, but that's another treatment pathway. There's the implant, which is a hypoglossal nerve stimulator, advertised as Inspire. That's for moderate to severe sleep apnea if people don't tolerate CPAP. There's a new medication that was just approved last month called Zepbound, which is tirzepatide. It's a weight loss medication, one of the GLP-1 medications, but that was the first medication approved for sleep apnea. There are other implants coming, other medications coming. So lots of options potentially. If you've struggled with CPAP, I would say if it's been a while, try again. There are newer machines, smaller mass. You can lower the settings, people can tolerate it. So it might be worth checking back in with a specialist. But if you have really exhausted that option, plenty of other things to consider for treatment.
Yeah. Similarly, any advice for minimizing or eliminating snoring? Special pillows or bed that raises, anything like that?
All those things I just listed would potentially reduce snoring as well. If you're snoring, I would think about sleep apnea too. So if you've not been tested for sleep apnea, it's a good idea to have that assessment. Other things you can do from home, saline sprays, rinses, again, breathe right strips or other nasal dilators can be helpful. Some people are trying mouth tape. You may not tolerate that if you're having trouble breathing through your nose. Yeah, elevating the head at night, 20 or 30 degrees, being off your back may be helpful. Avoiding alcohol near bedtime because it's a muscle relaxant. That might help with snoring as well.
Yeah, interesting. Uh, Last question from the audience. Any research on acupuncture to promote sleep?
There's some evidence that it can help with insomnia, and I think generally can reduce anxiety and pain. Not well studied, but there is some data that supports that. I would say you can try it. I think it's fairly harmless to try, and if you find a benefit there, continue it. If, as with anything, if it's not useful, then set it aside and pursue some of these alternatives.
Yeah, some personalized medicine. I've also heard of breath work and yoga nidra. Is that kind of along the same lines? Some research and then more personalized?
Yeah, I think again, harmless, easy to access YouTube videos kind of to learn about that and how to do that. May be helpful, may help to relieve insomnia, anxiety, pain. Again, if you use it and say this just isn't enough, don't feel like a failure. Just move on to another option.
Yeah. Couple minutes left, but I'm very interested in your opinion on this question about nightmares. So we've heard from patients that talk about having nightmares since their diagnosis. Any thoughts on how that relates to sleep?
I would wonder if these folks have sleep apnea. So again, with REM sleep, very vivid dreaming, muscles of the body are paralyzed, so you don't act your dreams out, often associated with nightmare recall. The airway muscles are paralyzed. And again, if you're having difficulties there with swallowing, speech, etc., in the context of this illness, I would consider also that in REM sleep, the muscles of the body are further paralyzed. Airways blocked, your brain's going to wake you suddenly by releasing cortisol, stress hormone. You're going to wake up suddenly from that dream, recall a nightmare potentially, and have more frequent awakenings. You can also have fragmentation of your sleep in a way that you can sleepwalk or have other sleep-related behaviors. And again, it's because the sleep is broken. You're in a mixed state of consciousness so that you can get up and move around. You're not aware of what you're doing, so you would know not to go wander around the house at night, but you're not conscious enough to avoid that. But again, why is there fragmentation? Why are you knocking yourself out of REM sleep, or why are you having behaviors around sleep that you didn't have before? I would worry or at least wonder about sleep apnea as a cause of that.
This is all very, very interesting. And so I hope that people, if you're hearing anything that you're experiencing, make sure that you're talking to your doctor and advocating for yourself. And if anything, we've learned today how important sleep is and all of the great things. So I do want to end on a positive note. That one was maybe a little bit of a downer, but I would just love to hear your perspective on what is a healthy bedtime routine to promote sleep, natural ways to promote sleep, any kind of standard advice that you typically give to help people get better rest and better night's sleep.
Yeah, so I would emphasize the idea of consistency, that your body likes regularity, and a consistent sleep-wake schedule is going to be very helpful. That means getting up at the same time every day, likely with an alarm, reinforcing that with light exposure, 15 minutes within 15 minutes of waking is a good rule. Have a routine in the evening, the last hour, maybe 2 hours of the day that you transition away from work and responsibility to things that help you to relax. And that might be reading, watching TV, listening to music, doing other kind of quiet activities, and often following the same patterns. So you're, again, reinforcing conditioning that I am preparing eventually to transition to sleep, just like we have a pattern for children. I think it's good to have that same routine in the evening. Again, turning down lights, avoiding stimulating activities the last hour of the day, especially. Keep the environment comfortable, lights down, dark. Avoid noise overnight, temperature cool. Those things are going to help promote sleep as well. You can build a strong sleep drive by staying awake through the day, minimizing naps, avoiding caffeine late, being careful about alcohol close to bedtime. And you can optimize your circadian pattern again with consistency in your schedule and that light exposure. But it is fairly easy to manipulate these things, and you can see benefits quickly within a week or two of making some of these changes. I think you'll notice some difference in how you're feeling, how you're functioning during the day. And sleep is very responsive to these kinds of changes. That's why CBTI is so effective, is that people notice differences within the first few weeks of therapy.
Dr. Peters, this has been such a fascinating conversation. So we're just about at time, and I just really, really want to thank you for your time and expertise and patience with all of our questions and the rabbit holes that I led us down. This has been an absolute pleasure of a conversation to have with you. So to the audience, thank you all for joining us. If you have any questions, do not hesitate to email, call us, or refer to our website for additional information. If you liked this program, there are a few things that you can do next besides go sleep. I hope everyone gets a good night of sleep tonight. But a couple other things that you can do next besides have a good night's sleep. Please be sure to check out all of the resources on our website. We have so many ways to raise awareness as well for GBS-CIDP, MMN, and related conditions, whether that's by sharing your story or volunteering. Finally, you may also want to consider donating to the foundation so that we can keep programs like this free for the community. And please remember that we are here as a community for you on your patient journey. So please use us as a resource. Dr. Peters, thank you again. And until next time, we will see everybody at our next webinar. So stay tuned for more information on that. Thank you.